I would thank Mr. Marangoni for inviting me. I'm very glad to be here. So, I'm an aesthetic surgeon. I started in 1982, so it's been a while. And my motto is the best result being the less invasive as possible. So the importance of the anatomy of the face is fundamental, and even greater attention should be given when you treat the rejuvenation of the face. But the area is very wide, so we will treat only a few areas. I particularly like to show you this picture because it makes you understand the stratification of several levels of the tissues of the face where we can perform our techniques. Very often we have to use several methods to get the best results. So if we see it from the outside to the inside, we have the dermis, and the fat compartments, the superficial fat and deep fat compartments, divided by the so-called SMAS, the SMAS. This is like a second skin that puts in contact the mimic muscles and divides superficial fat from the deep fat, from the nerves and vessels, which are so important in our face. And then after deep fat, we have the periosteum layer. But I would like to point your attention to the retinacula cutis. What are these? These are sort of ligaments where structures which are inside the fat compartment, whose direction is completely different from the SMAS and the dermis, compared to the retinacula cutis, which are found in the deep fat compartments. These retinacula cutis, in certain points, get tighter, denser, creating ligament structures which are more resistant, and they can also build up ligaments. The space between the SMAS and the dermis is the one where, in most of the cases, we interact, both concerning the injection of fillers and the endolaser itself. I would like to focus your attention on the lower third of the face. I started adopting this technique because I realized that during my daily work, many of my patients had sagging skin in this part. And I'm talking about as a doctor, not as a surgeon, so it's hard to have a retraction of the skin. I use several traction threads, but in many cases, satisfaction was not enough. So what about the jawline? The jawline anatomically divides the cheek from the chin and the neck, and it gets altered over the ears. So the jawline is deformed. There's an interruption of this line. We will see why the line is interrupted in certain points. And we also lose the angle, so the definition of mandibular angle, which supports us. And we also lose the definition of the cervical chin angle. So everything goes towards the bottom. What are the characteristics of a jawline? It's a very straight line which creates the triangle of the face in the young face, and for several reasons is then compromised. But this change is gradual over time, so we go from a light alteration of this jawline to an advanced alteration. Which are the anatomical structures that form the jawline? Of course, the bone structure, the mandibular base line, so the lower edge of the jaw, which gives the shape, and the bone structure over ears is gets a resorption. As you can see, in the yellow arrows indicate the areas where there's more resorption. Even in the chin, it is better to improve through fillers this bone reabsorption. Of course, we must also pay attention to the alteration and arbitration of the mandible and everything that has an impact on the lower part. So, arbitration or protrusion of the chin. And then we have muscles. These are fundamental. We should watch our patient during the visit. You can see how this patient there has a particularly strong DAO, hyperactivity of the depressant muscles of the mouth. So these muscles delimit the line, so the DAO and also the platysma. But there are also cases of hypertrophy of the muscles, for example, the masseter, which can alter the harmony of the face. And you see, in this case, there's an hypertrophy, which can be treated with botulin. An important muscle is the platysma. Today, well, it's been a while now, we've been using treatments for the platysma. As you can see here, a normal platysma, when contracted, appears like this. It is a surface muscle which works together with the DAO, and when it is contracted, brings everything down and alters the jawline. So you can use the botulin toxin to reduce the depression of the platysma and uplift the jawline. Again, this is platysma muscle. Something interesting, and several studies have been carried out about this. We think about the platysma as a muscle that arrives to the jawbone, but sometimes, well, very often, it goes upwards, almost to the line above the mouth. Here you can see a platysma, and this is a cadaver lab. Another important part that has a strong impact on the triangle of the face is the volumes due to the fat pads. We've seen so fat can be superficial or deep. Below this mass, we have deep fat. And this is what you see in the mandibular line, subcutaneous fat, where we interact. So from the cadaver lab, as you can see, this area of fat here is a superficial. In this area, where we inject filler or optic fibers, there's no nerve or vascular structures of importance. So if we keep our work to this superficial layer, we avoid side effects. But if we reset, you see, this is a filler which was injected to define the mandibular line. There's fibers, septums, and the fat that we can see at surface level. But if we go even deeper and we remove the superficial fat, we will have elements under this mass that are dangerous and we should avoid them. So this is the platysma going up towards the upper part of the face. But what happens to this fat? This fat is modified over time, and unfortunately there are some areas which tend to hypertrophy, or there is not enough fat usually. So in this area of the temporal bone area, there's a skeletonization. So some areas lose fat in the zygomatic arch. So there's an hypertrophy at the mandible, and so we should remove fat. In the nasolabial fold, so on one side we should fill with fat, and on the other side we should remove fat. And we should not also forget the excess of weight. So this patient was overweight at 20 and then lost weight. An important consideration is the ligaments. I said that the fibers get dense and create ligaments. These ligaments can get to the dermis, important ligaments. Of course, are these real ligaments or fake ligaments? I just indicated the most important ones. These ligaments determine, through traction on the skin, the folds that we have on our face. So as you can see, we got the masseter ligament, all the masseter ligaments, the mandibular ligament, the orbitomalar ligament, and the zygomatic ligaments. And you see how the skin goes down over time. So I talked about masseteric cutaneous ligaments. It's a series of fibers that can get to the zygomatic ligament and determine, with their sagging, the alteration of the jowl. So we could do something for the condensation of these ligaments of the masseter. And then I should also talk about the mandibular ligament. So what happens? It stops the skin, adheres to the skin, and the skin that is on top of it goes down and creates a fold. So you see, there's a fold created here, and the deformity appears between two ligaments. Why? Because in the face we have a fixed area and a mobile area. We have the fixed mass and a mobile mass. The one which is in behind the masseter is fixed, and on the opposite part of the masseter we have the mobile mass, and so a fold is created. Of course, we should talk about skin relaxation, alteration of collagen, photoaging, dermoepidermal restructuring. So we assess the quality of the skin. The innervation, very quickly. Of course, it's important to check the innervation of the mandibular branch, ophthalmic branch, with the mandibular nerve and the chin nerve, the buccal nerve. This is the mental nerve. And then there's the facial nerve, which is very deep below this mass, but is very important. There's another area where there's an emergency of the marginal mandibular nerve, and we cannot heat the area unless we want an alteration. Here, there is the connection between the mandibular nerve and there's 1.5 millimeters between the ligament. Well, this is not important. Which are the double structures? The important ones. What should we pay attention to? So the facial artery. Of course, it is on a deeper layer. We cannot reach it because the facial artery is below this mass, passes in front of the masseter. If you put a finger, you can feel it pulsating. It goes upwards and continues to the angular artery, which is then connected to the branches of the ophthalmic artery. I'm just saying this because I don't want to go in to look at the details, but this is an important connection with the external and internal carotid. So, not with laser, but we had cases of embolization and the patients got blind, but I don't have enough time to explain this part. So starting from the outside towards the inside, the structures that we should pay attention to. As you've seen, here we have the fat, and this is superficial fat. We are on top of this mass. This is the area where we work with laser. The green is the filler. These are trainings on cadaver labs that I carry out in Budapest. So it's very interesting. This is the level. So below this mass that we have, the parotid masseter, these white threads are the facial branches, and this is the mass, which was removed. So if we have a look at the video, here we are removing the superficial fat, this mass, and we are now below these structures that we don't have to touch. We have always to visualize the tip of the cannula, the tip of the fiber, of everything we use. If we go even below and we move the masseter, you see the jaw and the mental nerve. So again, facial artery. So you can see we reposition everything. These are the several layers. These are the levels, simple, moderate, or severe. And to conclude, I have something on the eye, but I'm not an expert on the eye. Just a few elements, anatomical elements, is knowing where we can act. Orbital fat, well, someone put filler here, I don't agree. Orbicularis muscle, superficial cheek fat. Well, these two areas, the roof and SUF, are the two areas where we either add or remove. These are the different compartments. So we have superficial fat of the eyebrow, and then we have the roof, retroorbicular fat, and SUF, suborbicular fat. So in the roof is divided in two parts, the orbital roof and the palpebral roof. So one is on top and one is below. Very often you see this hollow space above the eye that we have to fill. And the lower part can show hypertrophy. We usually don't use hyaluronic acid, but we use autologous fat, so we don't fill the SUF, and the festoons are another alteration. So we can have a retraction of this area of this relaxed skin, and the SUF, which is between the orbital ligament and the zygomatic ligament. But I would like to focus your attention on the SUF. It is in contact with the periosteum, so we have the muscle and its orbicular part and the malar fat pad. Again, we see here the SUF in the cadaver. Something very important is that the SUF is crossed by the lymphatic system, lymphatic vessels. So these drain the lymph, but the drainage is extremely complex and peculiar. So positioning some product, especially hyaluronic acid, in the SUF, because you know the degradation of this acid can hamper the drainage of lymphatic vessels. So after 1 month, the patient says, I have bags under my eyes and it's a mess, you know. I like to conclude with Face Anatomy, a new edition of an anatomy book that I wrote in Italian, English, and Russian. The images that you've seen are taken from these books, and then temple, eye, nose, lips, in anatomy and aesthetic correction of these difficult areas. I hope I was not boring, but I think that the anatomy is the base, the foundation of what we do on the face. Thank you for your attention.